Good afternoon. Welcome to the MAPP 2.0 overview. This is one of the trainings in the IPLAN webinar series sponsored by the Illinois Department of Public Health through the Community Health Assessment and Planning Grant. So we're happy to be here with you today. And, let me get my slides moving here. They're not moving. My name is Lori Call. I'm with the Illinois Public Health Institute, and I'll be joined today by Samantha Lasky, also with the Institute. And we have two great peer presenters today, Rachel Hendrickson from the Boone County Health Department and Dr. Sandra Motel from the Winnebago County Health Department. So thrilled to have them. We're going to do just a little quick introduction by a Zoom poll and find out who is on the call based on what your experience is or familiarity with MAPP. There's no right or wrong answers here. We just want to know if you're familiar at all with MAPP 1.0, the original MAPP, or MAPP 2.0, or not at all. And then we have a second question that we're going to open up also, which is what are you most curious about with regards to MAPP? And Samantha, are you able to open those? Great, thank you. So you want to scroll down on the right so you can see both questions? And let me know how we're doing on response rates, Samantha.
We're only about 44%.
Okay. So if you're participating by phone or you're multitasking, if you could just take a quick look at the poll for us. Love to get your feedback. Let me know when we're at least 60.
We're at 70% now.
Awesome, thank you. And do you want to share those results, Samantha? They're on my other screen.
Yes. So it looks like about 46% of us said that none for their experience. And followed by 29% being familiar with MAPP 2.0, 27% being familiar with MAPP 1.0. Only 10% only 17% have used MAPP 1.0, and only 10% have used MAPP 2.0. And then when we asked about what folks are most curious about, we heard timelines and synthesizing the CHNA and IPLAN process, the differences between the first and the second, engaging steering committee members, gaining knowledge of MAPP as a whole, but getting the best way to get started with no experience, the community context assessment, wanting to just, again, tips for implementation, and a lot of folks wanting to know about the difference between 1.0 and 2.0 and how it applies to MAPP.
Great, great questions, and I hope we'll get to most of those today. And if there's something we don't get to, we'll follow up with answers or a link or more where you can access more information. So thanks for participating in those polls today, and we'll just keep moving along here. So our agenda today, we're really just going to explore what MAPP 2.0 is. We are going to talk about the difference between MAPP 1.0 and MAPP 2.0. We're also going to share the practices and principles of MAPP 2.0, some definitions that really ground the work related to MAPP 2.0, and we'll look at a difference between IPLAN and MAPP 2.0. So I know many of you who have probably seen MAPP as an equivalent planning process for IPLAN have seen the old MAPP crosswalk. We're doing some work to update that, and we have a preview of that today to share with you. We'll then dive into the 3 phases of MAPP, and some of you are mentioning specific assessment activities. We will take a look at those assessment activities and also hear from 2 health departments on how they've done those, 2 of those assessments. And then we'll talk about the action planning portion, the community health improvement planning portion of MAPP 2.0. And we've got a couple activities built in here that even if you're not using MAPP, you could integrate into your existing process with IPLAN because they're just tools and practices that you can use to improve your overall process. So we hope those will be useful to you, whether you're doing MAPP 2.0 or you're using the IPLAN process. Okay. Next, learning objectives. We hope that by the end of this, you'll be able to use a few questions to say, is MAPP right for us right now? Maybe it's not today, maybe it will be in the future. There are a few questions that we'll just leave you with for that tool that you can use back with your health department and team. We hope that you'll be able to describe briefly the three phases of MAPP. It used to be, I think, 6 or 7, and now it's down to 3. And show us or tell people one way that equity is woven throughout the MAP process, and define some key differences between IPLAN and MAP. So those seem to line up with what you're curious about. I know you also asked about timelines, and we do have some information on timelines as well. Group agreements for the training. I think you all are great, and we just want to let you know that this is a training where you will be participating a bit more than the last in the series. So if you are multitasking, which we all have to do, we hope that you'll actively participate in the training. We've got a few breakout groups that we want to do some activities on, and they're mostly just to introduce you to the tool. You won't get completely through it all and feel like, oh, I did that whole tool, but you will get a good introduction to it. And so we'll be moving you along there. If you have any questions throughout, you can put them in the chat. We may not answer them until the end or even have to follow up with them, but we will answer all the questions to our best of our ability. And if things come up that we need to put in a parking lot and get back to you later, we'll certainly do that, but we will get back to you. If there's anything else that you need to make today's training successful and comfortable for you, please put a note in the chat or contact Samantha and let her know, and we'll take care of it. So we're going to start off by just what is MAPP 2.0. And for those of you who don't know what MAPP stands for, it's mobilizing action through planning and partnerships. This is a tool that was developed by NACHO, the National Association of City and County Health Officials, and CDC and other national partners, but also many of you in Illinois from the field who have been MAPP users. You either participated in part of the MAPP evaluation or other work groups or some of the advisory committees that helped develop this tool. So I want to say thank you to all of you in Illinois and beyond. Illinois has been one of the states that has used MAPP quite a lot because we've had a requirement for IPLAN longer than most states. So we have been considered fairly progressive in that area, which is exciting. These are the tools. So one of the things that came out of the evaluation was needing more a guidance on how to do certain things. So there's no shortage of materials for how to do these things. They're all produced by NACHO, and they're really beautiful and easy to follow. They're all free downloads. The only way you get printed versions, I think, is if you go to the training, a paid training, and you go through that training with NACHO. But you can print these yourself, and they're available at the link on the website here, and we'll be sharing in the chat as well. So MAPP 2.0 is really a framework, but it's a roadmap as well, and it's a roadmap or a guide to health equity. The purpose of this assessment and planning process is health equity. It's embedded throughout the process, and health equity is, and it's also intended to be the outcome or the result of doing this. So you might remember that they had a visual that looked like this in the past, and people really liked it and it resonated with some folks. And then other folks prefer a visual more like this, where you see the components and the phases. But regardless, there are three phases in MAP. The first is building the community health improvement foundation. So it's all the pieces that you need to think about, all the things that you need to put in place in order to have a successful process. And this can be as robust as you need it to be. Some of you who have, a smaller health department, a smaller number of community partners, and you don't necessarily have a huge staff that's going to be dedicated to this or portions of their time dedicated to this, it may mean that you need to, these tools can be really helpful for you in phase one because you're thinking through it, or it may mean that you don't have as much time to use all these tools. So the tools are there. There's nothing in those phase one tools that's absolutely required, but they are things that will help you be successful as you think about your past process, what's worked and what hasn't. You intentionally spend time thinking about how you're going to improve that and how you're going to set up this particular process for success. So there's a lot of really great tools in there that I encourage you to take a look at, and we'll review a few today. Then there's phase two, which are the assessments. There are three assessments in this process instead of four, and we'll go through all those today. And then phase three is really the community health improvement planning portion of the work. MAP, the original MAP had gone through a couple updates over the years, and then which was developed back in 2001, and then in 2019 went through a full evaluation process. And our very own University of Illinois at Chicago School of Public Health folks led that evaluation, and you may, if you're a MAP user, may have been someone that they contacted to get some input either through a focus group or a survey. And these were really the overall evaluations that came out of that, or overall recommendations that came out of that evaluation. So that people said that we need more enhanced resources and guides and training and direction for how to use it, because MAP 1.0 was flexible, but it wasn't clear all the time how you do certain things. So there's supposed to be more how to here, but it's not intended to be more scripted. It's still flexible, but there is more how to. They wanted to make it more applicable to a broader set of communities. And so MAP has been used in the Army, health services, a variety of different types of communities rather than just a health department jurisdiction. There are MAP 1.0 is intended to be community led, community driven, and so there are more tools, more processes for how you can really enhance that community engagement and those other groups and organizations. You'll see the word stakeholder in here, and NACCHO is trying to move away from using that terminology, which can be interpreted as derogatory to some communities. So it's still in some of the tools and the workbooks for NACCHO, but they are trying to move away from that definition. So in several places, you'll see that I've just replaced it with groups, organizations, individuals, partners, entities, those sorts of things. Um, they wanted to address places where there were gaps or inefficiencies where people said there's not enough information or there's not enough guidance. And they wanted to really streamline. And so they've shifted from 4 assessments to 3 assessments. And this is just a really quick comparison of MAP, the previous MAP version to MAP 2.0. I won't spend much time on this, but it is a supplemental resource. So from 6 phases, the original one, to collapse to 3 phases that are pretty easy to recall and remember, from 4 assessments to 3 assessments. And the biggest change is that the previous public health system assessment, which called on lots of folks to come in and really rate how well the system was doing in administering the 10 essential public health services and scoring all those things, that has been eliminated. And there is a community partner assessment that we're going to hear how Boone County administered this past cycle for them. I mentioned this focus on community engagement previously. That's still an important focus, but the ultimate rationale for that is really equity, and equity as a process and an outcome. Previously, there was an optional health equity supplement. Now it's just embedded throughout. And there is an excellent resource, the Power Primer, that you can use with tools for ways that you can help build the capacity of your steering committee, of action teams, of your organization, of groups you're working with. So it's got some great activities in it that can help you as you're building their capacity for health equity work. And we'll do some of that work today and in an upcoming training in October in integrating health equity throughout the process. The original map was intended to be flexible with guidance, and this has even more guidance and more adaptability to be responsive to community needs. And then finally, the suggested structures for how you organize things are a little bit different. There's actually more suggestions for structure. So when you're engaging people, there are lots of opportunities for really defined roles that they can play. So that's just a high level overview. And any of you who have used MAP, you are familiar with the differences between MAP 1.0 and 2.0. If you have another observation or something else that's different, feel free to note that in the chat, and we'll take a look at that and share that out as well. So just a couple notes on definitions, and I wanted to share a couple things with you here. That centering equity is just a really key part of MAP 2.0. And I've said it's both the process and the intended outcome. So you can see here the definitions that they're using for health equity definitions. Dr. Kamara Jones, the assurance of the conditions for optimal health for all people. And Margaret Whitehead, differences, health inequities are differences in the distribution of disease, illness, and death that are systematic, patterned, unjust, actionable, and associated with imbalances in power and systems of oppression. So you will hear that language quite a bit through here, and that is really intentional. So, despite many of our public health efforts, there's still many communities, even in our state, many in our own state, that do not have the opportunity to achieve the level of health that they would like to. There are differences in opportunities and what we call health inequities, those preventable differences in the distribution of disease and death that are systematic, patterned, unjust, and associated with imbalances. And there's also challenges we have in our own state about using some of that kind of language, and that language being palatable and understandable to people. So there are some tools and some guidance around if you are a health department where in a community where this language is harder to talk about or harder to use, there are some suggestions and some guidance, and there are some nice tools to sort of start warming people up and start introducing people to concepts without, hammer nail type situation. So let's pause here. Let's pause here and do a very quick poll to see the range of experience in talking with community about advancing health. So there's three options that you can select. How comfortable or what's your organization's level of experience in talking with community about advancing health?
Looks about 70% of folks have responded so far.
Great, great. So my organization just starting to have conversations about health equity with our community seems to be the highest at about 51%, followed by 25%. My organization is an expert at starting these conversations. And then 21% are not quite sure where their organization stands. So great data. And again, I think this will be really, really helpful. So I wanted to mention also on this health equity action spectrum, which is a tool developed by NACCHO that is integrated throughout MAP as a framework and tool that can be used to help understand how health equity is integrated. So, to achieve true health equity, communities must address the underlying systems of power, privilege, and oppression that drive inequities or the root causes of health inequity. So, on this spectrum, what you'll see here are these are items that listed on the left side, the effects such as racism, capitalism, and white supremacy that impact and produce those root causes. The root causes of health inequity were initiated through colonization of the exploitation of enslaved African people through chattel slavery to build America. This is something that we know. The laws, policies, and norms that were designed to maintain these systems compose our institutions today and have created conditions which are at the center of the spectrum that lead to the exclusion, marginalization, and systemic violence across all types of social identities, in addition to race. So we're thinking about that intersectionality in addition to race. And I know that this language is sometimes language that is polarizing in communities. So it's looking at the guidance in the Power Primer and throughout MAP into it as to how to convey this message and let people have their own self-discovery can be helpful. So there's activities that we can take people through so that they can start uncovering these and seeing these and how they impact them locally. So these systems result in inequitable concentration of power, wealth, and resources with select privileged groups and leave other groups with scarcity and harm. So for example, power over funding decisions is often concentrated with organizational leaders or elected officials instead of community residents, despite the way it may seem. So MAP 2.0 is really designed with tools, talking points, activities that help begin these conversations with the community to help be able to build your community health improvement plans that can address these factors and have some lasting impact. And that Power Primer is really helpful in that aspect. But it does take time. And it's here I just wanted to point out that in Healthy Illinois, in the State Health Improvement Plan, social and structural determinants are identified as cross-cutting issues to address the priorities. And one of the 5 top priorities is racism as a public health crisis. So we do have support from the Illinois Department of Public Health down to be addressing this type of work. I just wanted to point out really quickly, this is really a supplemental piece for you. I won't spend a lot of time on it, but looking at the difference between social determinants of health and social and structural determinants of health. So social determinants of health are non-medical factors that influence health outcomes. So conditions in which people are born, grow, work, live, and age. And the structural determinants of health, written and unwritten rules that create, maintain, or eliminate durable and hierarchical patterns of advantage between socially constructed groups in the conditions that affect health. So the power relations that people and groups will have with more power um, uh, work to maintain their advantage by reinforcing or modifying these rules. So that's why it's so important that we really dig deep in looking at power, and we'll do a quick activity we hope today to be able to do that. Another one of the underlying pieces that really goes throughout MAP 2.0 is the spectrum of community engagement. And so you've probably seen this in some format. It goes all the way from ignoring the people in the community to deferring to them to make decisions. And so the highest level of community engagement. And a lot of times our organizations fall around informing community where we're providing them with information and facts, or maybe we're consulting with them and we're asking for some of their input through focus groups or surveys. But moving to that involved stage where we're ensuring needs and assets are woven throughout the process, that their needs and assets, and that we're collaborating where the community plays a leadership role. They're co-designing, they're co-implementing, co-managing, co-leading a set of solutions, are deferring to, we tend to not be on that end as frequently as we are on the other end of the spectrum. So the goal is to continually be striving and moving and advancing through that spectrum. But there are times where pieces are more appropriate to be on one end versus another. So this is a good tool to use no matter what you're doing when you're working with the community to think about where are we and what would it take to move to the next level if appropriate. Foundational principles for MAPP. We've talked about a few of these already. We've talked about equity and somewhat community power and inclusion, but there are others about being flexible and continuous in the work and continuous quality improvement, building and developing trusted relationships with community and other partners, data-driven decision making and data-informed action is a really important piece. Strategic collaboration and alignment, not going alone, but doing this together. So quite a bit of these principles are carried over from the previous map, but also expanded on. And then here you'll see the practices. The one I like the most is start where you're at. So if you already have a lot of data from the community or you already have structures in place, you don't have to do those steps over. You start where you're at. If you already have a community vision, you don't have to do a new one. So that's really what that's about. Building whole community partnerships is another goal. So you want that to be continuous throughout the process. You're always thinking about who are potential partners that we can engage, where and how we can engage them. You're constantly updating the data to tell the community story. You're at least doing that, on a regular basis. You're mobilizing the community for action, for implementation, and for looking at the data and providing data, and ultimately focusing on transforming systems. So policy and systems change, environmental change are huge in the strategies for MAPP 2.0. And of course, we're doing all of this for health equity. These next three slides are a flow chart of the three phases. So this is the flow chart for phase one, which is building that foundation for the work. And you'll see here where we've put a couple stars. Those stars indicate that these are places where it's very similar to IPLAN or the IPLAN process. So there's a steering committee. You're defining a community vision or mission, which is similar to what you're doing as a purpose statement in the IPLAN process. In phase two, you're collecting the data from the community. So the community status assessment is similar to the IPLAN requirement. Community context assessment is gathering information from the community about the community, and it's a requirement that you have community participation in the IPLAN process. You're looking at all the data from the assessments, and it's called triangulate in MAPP 2.0 because there are three assessments. But in IPLAN, it would be however much data you have. You're really analyzing and looking at that as a whole, not just individually. And then you're in the MAPP 2.0, you're developing issue profiles by looking and digging into the root causes. And in IPLAN, we're also looking at risk factors. We're looking at indirect and direct contributing factors. So we are digging in and really understanding those priorities. In phase three, this is really the community health improvement part of the process, and we're prioritizing just like you would for IPLAN, and IPLAN requires a minimum of 3 priorities, whether you're using IPLAN or MAPP, and you're developing goals and objectives and strategies, the action cycles, and you're developing a plan for monitoring that work. So again, similar to IPLAN, and you can see where those similarities are. This is just a picture of the high level of an IPLAN process. And again, I put this in here for your reference later. We won't spend time on it today. And I've also included this crosswalk that shows in the first column the high level IPLAN process. The second column is where there are activities that are similar to that throughout the MAP process. So it may not be in the community health assessment. It may be in the community health assessment and the community health improvement plan portion, or in the building the foundation. It could be in any phases of MAP. And then the third column here is what that IPLAN substantial compliance indicator is. So what you are required to show where it's at and what page number it's on when you submit that to IDPH. So it's easy to find. So this is a fresh draft. I've got some early feedback from some MAP users, but we're going to continue to refine this and flesh it out even more if there are more edits. But I'm introducing it to you today, and you'll have it in the slides. We will be giving you a copy of these, and you'll be able to look at it in more detail. So I think it covers 3 slides, and there is one additional piece in the IPLAN process that you don't have to turn in, that organizational capacity assessment. There's not an equivalent in MAPP 2.0 for that because there's not a self-assessment component necessarily. So I just did want to note that. And then Samantha has a handout for you on this, but these are the high level questions that you can really ask yourself. And you can look at them from the handout. Is MAP right for you? Is health equity part of your health department's vision and your community that you're working with, the community team that you're pulling together? Are you all interested in partnering with organizations across sectors and not just health and public health? And I think that you are. Are you committed to authentic community engagement where you're really listening and you're really using that information and you're sharing power? And can you dedicate the necessary time? Because what I didn't mention in these flow charts here, this phase 1, if you're doing all of these activities, and again, you don't have to do everything, you do what you need, could take about 9 months in getting ready for it and really building the foundation and the structure. Collecting all of the data in the 3 assessments could take another 9 months. And then the action planning could take a minimum of 6 months. Now, some people may be able to shorten that, and some people may lengthen it, but those are estimates. And I am going to get us back up here to phase 1. I think I've gone a little bit over time here, so I'm gonna just move us along in phase 1. If you do have any questions, though, please go ahead and bring them up. We do have an activity planned in phase 1, and I'm understanding from some texts that are coming in that we're having a little bit of technical difficulty, so we're going to modify the way we do that activity, I believe. So we're going to look at phase 1. And in phase 1, these are the goals. It's really, again, about building that foundation for community health improvement. This is where you start involving community members, you start identifying partners, other organizations, groups, even folks you have not worked with before. The goals are to build relationships and start building those relationships, not just when you need something from someone, but all along the process. You're establishing your core group of people at your organization, or if you're partnering with hospitals or an FQHC or a United Way or multiple to do this because you all have the same requirement. This is where you're establishing those relationships and that connection, and maybe there's contracts involved. Whatever it is, that's where you're doing this in this phase. You're developing a shared understanding of the process. Maybe you're bringing some training in for folks. You're all getting on the same page and engaging the community to form a vision. And you're taking a look at what resources you have, what resources you need to do the process, and you're really building that infrastructure to do it. So there's a variety of different steps. We're going to talk just about a couple today. One, we're going to talk about a stakeholder and power analysis, and we're also going to briefly talk about the starting point assessment. So the stakeholder and power analysis is a tool that is used here, and it's also used in the community health improvement planning portion of the process. We're going to do an activity related to it in the community health improvement planning portion. But here in the stakeholder, in phase one of the stakeholder analysis, the steps are that you're really going to brainstorm who are all the potential people, organizations, groups that could be involved. And this is a helpful tool to look at because it has different sectors of the community and potential entities or organizations or groups that could represent that, and really just kind of pushes your thinking. Because what we want to do is we all have the usual suspects you've been engaging for 30 or 40 years from your health department, but are there any other organizations or groups or entities that you might want to engage? Maybe some folks who are not traditional in terms of who you always invite or bring to the table. You're going to be getting to know them. You're filling out some information about them in a stakeholder analysis table. You might do one-on-one interviews with them to get to know them better, have those meetings. You're analyzing your data, really looking across all that data in the table to see who you have, where you might have gaps, who could bring what to the table. So there's tools in here that even if you're using the IPLAN process and you don't decide to use MAPP, that can be really helpful in your IPLAN process, because in your IPLAN process, you're required to form a community health committee. You're required to think about how you're going to engage community throughout the process. So it can be helpful in that way as well. So let me just pause here and see, before we start our activity, I had an activity here where we're at on our technical issues. So, in the webinar. Okay, so we had planned to do some breakout groups for this activity, and it seems like it may not work as a breakout group, so we're going to do this as a large group discussion, a really large group discussion, but it's really intended just for you to start thinking through these concepts or things anyway. So if you could, I want you to think about some non-traditional organizations or groups that you could engage in your next IPLAN process, whether you're using MAPP or IPLAN as the process, no matter what you're using. Who are some non-traditional organizations, maybe that you've thought about, but you don't know how to engage? You've heard other people have engaged, somebody that you haven't engaged yet. So let's just start listing those folks in the chat right now, and Samantha can share some of those names. Oh, I think she's got a mentee. She's got a mentee that we can use. Samantha, if you'll put that in the chat, we'll just use that. Thank you.
Okay, everyone, and I can share my screen as well. So for those of us who have not used Menti before, you can use Menti on your phone by scanning the QR code on your phone here. You can use the link. I'm gonna drop a link in the chat to open in another browser. Or you can go to menti.com and type in this code. So we'll give everyone a minute to enter that and join the Mentimeter. Can you all see my screen? Oh, I'm sorry, Lori, could you stop sharing?
Yes, I can.
And once you're in the Mentimeter, feel free, you'll see a thumbs up on the screen. So click that thumbs up so I know folks are in here. There we go. So again, you can use the QR code, scan it on your phone using your phone camera. You can go to menti.com or you can use the link in the chat. And if you cannot open Menti, that's totally okay. Feel free to answer these questions in the chat as well. We've got 20 of about 68 participants, so about 70 participants. So we'll give folks another second.
Yeah, let's see what some of those responses are, and then we can go
Sounds good.
into the next question.
So the first question here is thinking about those non-traditional organization or partners that you might engage in your health community health assessment and improvement planning process. Do we want them to write it down? Okay,
Yep.
awesome. And again, feel free to participate in the chat if you cannot open the Menti.
Great, we're getting some good ideas here. Keep them coming. Immigrant faith-based groups, Community Health Partnership of Illinois, farm boards, LGBTQ Center, church leaders, mental health, teens, young people, rural, Chamber of Commerce, Department of Transportation, school leaders, first responders, school kitchen staff, love it. Child advocacy centers, youth sports, university students, grassroots organizations, veterans, local politicians, definitely, school social worker, um, pharmacies, after school program, migrant workers, neighborhood network groups, food pantry volunteers, park district, Big Brothers Big Sisters, housing services for the unhoused, assisted living, climate groups, academia. Great, great, great.
Wonderful.
So in our activity in breakout groups, we were going to list these and choose one or two and then answer the next set of questions. So let's just pick out a group, migrant workers. Let's pick migrant workers. What are some of the assets that they might bring to the chart process? So what might migrant workers bring to the chart process? What could you get from them? Themselves. They would bring themselves and their experiences, their lived experience. Yes, their lived experience. They know the gaps in the public services in the community. Absolutely. Different points of view, understanding of barriers of accessing medical or core health insurance, fresh ideas, their culture and their beliefs. So we would know more about that. You building trust with the government and how to do that, who they trust for information, their trusted sources. They know where we need better language access and those barriers. Um, you might not know until you meet with them. Different points of view, language translation, difficulties navigating our healthcare network. Okay, great. Those are all some great ideas. So, what are some strategies? Let's look at the next question. Um, what are some strategies you might implement to engage them? Oh, there we go. Thank you, Samantha. I'm sorry about that. Some strategies you might implement to engage them. So what kind of invitation or how might you invite them to get them to come, especially if they have some distrust? Maybe focus groups or a survey. If you're saying ask them or invite them, is there particular people or persons who might be better at asking? Are there some particular ways to ask them that might work better? Meet them where they are, great. Offer a stipend for their time, go to where they are, excellent. Food tasting gathering, meet them where they are or attend a group that they're already part of. Identify identify point of contact or a trusted member of their group. So some kind of connection that you have. Make sure that you bring people or have people who can speak their language. Have someone who they trust, a clergy or a prominent person. Have an event and have food involved. Partner with organizations you know they trust or go to for services. Great, great ideas.
Someone put
Um,
in the chat to ask in person where they are and invite them.
Excellent, excellent. And have any of you have any experience with engaging these folks? And what have you learned? Anybody have any experience and what have you learned from engaging them? Has anybody been able to engage my migrant workers yet? There is a lot of mistrust of the government, so that's a learning for sure. So we really have to be thinking about who the messenger is, who brings them in, how we engage them, how we build that trust. Anyone else? It's important to be clear on what our systems can and can't offer. So we shouldn't promise things we can't deliver. Thank you. Anyone else? I think this is what we're trying to figure out. If the person or group doesn't feel comfortable at the table or doesn't know that there's room at the table, it's hard to get someone to our door. Exactly. So this is what we want to talk about, right? Talk about in this phase is it's not just the same. We can't do the same strategies for everybody. We're not going to be able to just send an email to people who aren't at a computer all day and don't just trust a cold email. It may have to be, that you have a one-on-one meeting first with someone who is a trusted entity in the group, and you meet them and you talk to them and you ask if you can come to talk to them during a lunch period that they have or a break that they have, something like that. So it's different ways to engage. Kindness and patience goes a long way, being honest and direct. Their food engages them, specialty food store. With new groups, we meet regularly with them when possible. Availability for individuals to participate or working hours may limit their time. Absolutely. Have a sound understanding of their culture before you go. And so we need to learn from them and from others who work with them and know them. Meet at their place of interest, coffee shops or libraries, those sorts of things. Lots of great ideas in there. Excellent. Okay, thank you, Samantha. We'll go ahead and pause this portion of the activity, and I'll reshare my screen. I think I can figure that out. Can't see. Huh. There it is. Sorry about that. And I need to
And just switch the display setting.
switch the displays then. Okay. All right. So great. So hopefully you'll see that that tool can be helpful. There are having that conversation outside of just your office, but with other folks to talk about who are all the people we could potentially bring in, and then asking those types of questions to explore that. When you're doing the stakeholder analysis after you've identified folks, you're thinking about what knowledge can they bring, and what knowledge do they have, what knowledge do they need. Alliance, so help them understand the local public health system, and also for us to understand the folks we're trying to engage, and then a power analysis. And as I mentioned, we'll do a power analysis in the second half of this training. So these are just some of the things that you would want to do as you're engaging folks. So are you sure this is showing the right screen? It is showing the right screen, right?
Correct.
Okay. All right. Another step in the process is just you're sort of plotting the people on a matrix to find out, you're interpreting these results collectively to find out, do they have high power, low interest, where are they? And that's after you've conducted that power analysis. So I'll leave this in here as a tool, but we don't have much time to look at this part right now. And we're going to revisit this in the chip, but this is part of the power analysis. So the next piece, the other big piece I wanted to talk about in phase one is the starting point assessment. And the starting point assessment is really a great opportunity and tool because it is really a place where you can dedicate time to quality improvement, to really reflecting on what you've done in the past and the way you've done things in the past to identify How can we make this even better? How can we achieve goals, different goals that we have for different parts of the process? Again, this is a tool that you could integrate into your IPLAN process. You don't have to use MAP to be able to do this because all it is some guidelines and tools for how you critically look at what you did last time and identify how and where and ways that you can improve what you're doing. So it's about looking at that and prioritizing what you want to improve and then creating a work group for how you can improve that. So for those of you who are going through public health accreditation or working on that, it's a great way to identify some quality improvement projects related to your CHA chip. So in the starting point assessment, these are the topic areas, the things that you're looking at to reflect on how the community health improvement cycle went last time or is going. Look at your level of community engagement, your partnerships, your data collection, all of those pieces. So I'm going to pause here at the end of phase one. If there are any questions for phase one, you can go ahead and put those in the chat and I'll start answering the chat while Samantha introduces you to phase two and we have our guest presenters share during this piece. I'm a little bit behind here, Samantha, so just a heads up and I'll turn it to you.
Great, thank you so much. We can go on to the next slide. Hello, everyone. So welcome. We're going to be talking about phase two. There's really two goals of phase two. The first is to engage the community in developing the comprehensive CHA or CHNA, community health assessment, community health needs assessment. And the second is to identify the top population health priorities and health inequities in the community, which includes their root causes. Phase one was really about getting ready and planning, and phase two is all about gathering data and conducting the assessments. Next slide. Okay, so here are the overarching steps of phase two. So as Lori noted, where you see stars or where there's alignment with with IPLANs. So the first phase is really to form the assessment design team. These will be essentially advisory committee folks who will help you manage and go through the assessment phases. Next will be designing the assessment process, followed by doing the three assessments, the community partner assessment, the community status assessment, the community context assessment, where you'll gather all your data. Step 4 is to triangulate data, identify themes, and develop issue statements. Step 5 is to develop issue profiles through root cause analysis. And step 6 is to share community health needs or community health assessment findings. Next step. There, next slide. Thank you. So this part of the steps includes developing guiding questions. Guiding questions are selected by the community to inform the implementation of the assessments, and they are hopefully to be answered from the assessments and from identifying themes to uncover your big picture of your community health assessment. The guiding questions are selected by the community for the community health assessment and inform all three, like research, project, or an evaluation. We are determining what we want from the assessment and what questions do we need the assessment to answer. So on the right-hand side, you'll see some examples of guiding questions pulled from MAPP 2.0 handbook that are options or starting off points or examples that could be used and applied to your own CHA. And we can go on to the next slide. Wonderful. So slide 3 or phase 3 of the step 3 of phase 2 is to really do all three assessments, the community partner assessment, the community status, and the community context. Where you see the yellow star right there under community status assessment, that is the assessment that is conducted to collect quantitative data on demographics, health status, and health inequities. It helps to identify inequities beyond health behaviors and outcomes, including social determinants of health and systems of power, privilege, and oppression. That assessment is aligned with the bulk of the analysis of collecting data for the community health issues and community health problems that is required as a part of IPLAN. And the community context assessment is, and I'll get into what each of these other ones are, a blue star because it is additional qualitative data from the community to help inform this data collection as well. Next slide. So, as always, before you begin, when collecting data, it's really important to think about where the data fits along the health action equity spectrum. Do they represent root causes of health inequities, like systems of power, privilege, and oppression, social determinants of health, social and structural determinants, health behaviors, or health outcomes? And how does the data from each assessment relate to and influence the other two assessments? Next slide. So we're going to start by getting into the community partner assessment. So the community partner assessment, the CPA, allows community partners involved in in MAPP to look critically at their individual systems, processes, and capacities. Two, collective capacity as a network of community partners to address health inequities. And it should be used to identify current and future actions to address health equity at all of these different levels. And it's often noted as a not equal, but not equal, but equivalent replacement of the local public health system assessment from MAPP 1.0. So next slide. Thank you. So the goals of the CPA are really to describe why community partnerships are critical to the community health improvement plan and how to build or strengthen relationships with your community partners and organizations, name specific roles of each partner in the local public health system, and engage the community's experience in equity produced by these systems, to assess each partner's capabilities and skills, to document the landscape of community partners, including your grassroots and community power building organization, to really understand and summarize the collective strengths and areas for opportunities across the local public health system, and to identify whom else to involve in MAPP and ways to improve community partnerships, engagement, and power building. Next slide. So overall, the steps for the community partner assessment are listed here. We're going to be I'm going to describe a little bit about administering the CPA survey and summarizing those findings. And I'm actually going to then pass it on to one of our peer presenters today, Rachel Hendrickson, in a moment, who will be able to go into the work that her health department did, Boone County Health Department, to adapt the CPA. Next slide. So, part of the assessment is the CPA survey, which is helping you to understand a partner organization's capacity and interest. Each CPA partner organization should only submit one completed survey to the person who's collecting the survey data. If multiple individuals from the same organization want to take the survey, it's advised to have them either identify one person, meet as a group and discuss it, or download the survey and have them take it individually. It's really to get a answer on behalf of a single organization for these pieces of the survey, which includes these following topics. I'm not going to list them out. You can see them here on the slide, but it's to really understand the strengths and areas for improvement for each of the community partners in their relationship to the health department. Now I'm going to pass it on to Rachel Hendrickson at the Boone County Health Department to talk a little bit about how she and her team adapted the CPA. Rachel?
Hi, thanks so much for giving me the opportunity to present today. I'm actually not able to turn my camera on due to host has stopped it. So if someone could turn my camera on, that would be great. Next slide. So we did adapt the community partner assessment, or the CPA, to our community. The CPA guide itself lists a couple options to make it a little flexible for your health department. They give you an option to host either one meeting or two meetings. In both ways, you send the survey out to participants in an email. But what we decided to do is we knew that we would lose partners, we would have low uptake of the survey if we had multiple meetings and then send it out and get lost in their inbox. So we did adapt it so that everything would happen in one. So we introduced the CPA, we did activities, and we had them sit there and take the CPA survey itself live together. So what we did as well to adapt it is we ended up splitting up our participants. One side of the room was general community partners, and the other side of the room was healthcare. And the reason we did that was to meet FAB measure 711A. So while we're trying to meet CHA-CHIP requirements for the state, we're also trying to simultaneously meet public health accreditation requirements. And 711A is engaging with the healthcare delivery system to assess access to healthcare services. So very similar to the other side of the room, but more tailored specifically to healthcare services. And something else that we adapted was Slido polling software. It's very similar to Menti, the software that we used earlier today in this presentation. It made it a lot easier to not only gather data, but do qualitative data analysis on the back end, rather than having frontline staff desperately writing down notes of what people are saying. They were able to not only have that in-person and discussion, but upload their thoughts and perceptions in the Slido polling software using their smartphone. Next slide. Going to touch on what worked well for us. The CPA guide talks about offering incentives. I think a lot of us on the call have issues with that. We don't have a budget to provide incentives to participants for anything. So what we've done is get sponsors from community partners to host breakfast and lunch. It was a long day, so it's definitely necessary to provide breakfast and lunch to them. And another success is we had really high attendance. We had over 70 community partners in attendance, which is a lot for our small jurisdiction. And I really attribute that to the Whose Voices Are Included worksheet. It's included in the CPA guide. It breaks down partners by different sectors to not only make sure that you are including as many people as possible, but that it's equitable, right? Making sure we're representing or getting representation from underserved and marginalized communities, and also regular follow-up with partners. We had frontline staff trained with message maps on who to contact, how often to contact them, what exactly to say. If something came up on an attendee's schedule, can you send somebody else in their place? So it's a lot. It's not just sending out an email and hoping people RSVP and come. It's that one-on-one, going out into the community, talking to them in person. If it requires that, the supervisors at the health department got together and looked at the list of attendees and thought, who has a good relationship with so-and-so, and so on and so forth, to do that tailored one-on-one outreach to partners to ensure we had great representation. And something else we used was Eventbrite. That was really helpful in gathering RSVPs rather than one person receiving, 100 emails for people saying yes or no whether they're coming. So that definitely helped. Next slide, please. Something else I want to talk about that worked well for us. The CPA guide has a lot of activities listed. And throughout the guide, they talk about tailoring it to your organization and your jurisdiction, especially when it comes to pieces regarding racial activism, health equity, social justice. Some people just aren't really ready for that yet. So substituting some language to make it more palatable for some folks. So some of the activities that we picked that we thought would be well received in our jurisdiction was the upstream and downstream activity, where partners listed out the different essential public health services they offer and mark it along upstream or downstream. More upstream is, the preventative aspects versus downstream is more reactive, and you need both to function, of course, in a local public health system. And that really showed us, how we're doing if we have more preventative services versus reactive, or if we have a good blend of both. And another activity that we liked to facilitate was the rich picture analysis. And you can see a digitized version of that on the screen. So what people had at the event itself, they had big pieces of paper on their desks, and they worked together to draw a local public health system for a hypothetical Boone County resident that the health department created based on real events here. For example, we've had the Chrysler plant shut down around that time, which impacted a lot of people in the community and their livelihoods. So we created a vignette about a hypothetical person experiencing that, for example. So that really helped bring it closer to home. Next slide, please. Thank you. And some improvements for next time, mostly logistical improvements because we split the room. There were some venue acoustic problems. The audio equipment wasn't working, so we had to pivot. There was construction going on in the building, so we had to do some last minute pivots to make it work. And even though we tried and prepped for the Slido polling software, there were still some software malfunctions. It wasn't accepting some people's email addresses. So we learned during COVID not to just solely rely on electronic means, but we had some paper backups as well to account for the software malfunctions. And some good feedback we got. We sent out a survey to our partners after to see how we did and how we can improve. We got some good feedback about sending out definitions and materials ahead of time. Probably would have brought people up to speed who maybe aren't familiar with what the health department does and what a community health assessment really looks like. Next slide, please. And then what did we do with the data? So something that we learned is that partners are unaware of what each other are doing. Everybody's doing a lot of good work. They really want to collaborate and they truly feel strongly about serving the community, but they just don't know that, you know, another organization across the street is offering these great services that they can refer their clients to. So we started hosting town halls where both community partners and community members can come and learn about transportation, access to care, and the different organizations throughout the county. We also learned that there is a dire need for translation services in our county. 25% of our population identifies as Hispanic and 16% speak Spanish at home. But a lot of partners reported that they don't regularly translate their materials that are forward facing. And we also learned that there is a need for DEIJ or diversity, equity, inclusion, and justice trainings in our county. And while partners recognize that there are health disparities in this county, they maybe lack the structure. They may not have a policy to reflect this. They may not have a job description dedicated to health equity. And that's similar to what we have as a health department, right? We're still learning. So we're dusting off our policies and processes and plans and looking at it through a health equity lens as well. So what we've started to do is not only, you know, revising our own internal policies, but working with our community partners, offering free DEIJ trainings. A lot of trainings are cost prohibitive. So just next month, we're offering 2 trainings to partners. And we also learned of new partners that we didn't even know about before. So a lot of partners heard about the community partner assessment event through the grapevine or different community partner meetings. So we've started to onboard new partners into our existing programming. So thank you so much for giving me the opportunity to present. That's all I had for the CPA.
Thank you so much, Rachel. I appreciate you taking the time to share with us and for us to hear from you and learn from your health department. Wonderful. Next slide. So now focusing on the, oh, I see that you already did, focusing on the community status assessment. So as you can see, we have another star here. So the community status assessment is equivalent to one of the steps in the IPLAN of the analysis of health problems and health data. On the left here, you can see that the community health assessment is a community-driven assessment that to help tell the story of the community. It informs and collects quantitative data on the status of your community, such as demographics, health status, and health inequities. It helps move a community upstream and identify inequities beyond health behaviors and outcomes like social determinants of health and systems of power, privilege, and oppression. By including community members and organizations that work with historically marginalized communities and people experiencing inequities, you help ensure the data reflects all voices. It should reflect your community's unique characteristics and members. On the right here, you'll see the IPLAN required data categories. So these are data categories that are required, and MAP 2.0 users must use at a minimum the IPLAN 7 data grouping. So demographic and care and socioeconomic characteristics, general health and access to care, maternal and child health, infectious disease, chronic disease, environment, occupation and injury control, and sentinel events. Next slide. Oh, one back. Thank you. So the goals of the CSA are to explore data about populations experiencing inequities and describe complex issues that impact your community. And it helps answer these questions of what does the status of your community look like, what populations experience inequities across health and all of these outcomes, and how do systems influence outcomes. Next slide, thank you. So overall, the steps of the CSA, the ones that were the steps of the CSA are very similar to MAP 1.0 and the community health status assessment, but you're really engaging your assessment design team. So ADT is the assessment design team, which is essentially the advisory committee, as I said noted earlier, the advisory committee that helps you identify and process and go through these assessments, and any relevant stakeholders that will be a part of this status assessment process, determine the purpose for your community, assess the value of existing community data, identify indicators to inform the CSA, collect that data, develop it, and apply the data collection plan, organize, analyze, and interpret it, compile your results, share with the community, and then, of course, monitor and evaluate. Next slide. I'm not going to do as much talking about the CSA myself because we're going to go in a little bit into the context assessment, which might be newer to folks than the community status assessment here. But we did want to note indicators for MAP. MAP suggests specific indicators, as you can see here on the left. They suggest downstream indicators such as health outcomes and health behaviors, social determinants of health. And as a reminder, the IDPH in the state of Illinois State Health Improvement Plan has social and structural determinants of health as a cross-cutting issue, and upstream indicators such as systems of power, privilege, and oppression. At the same time, as noted previously, all health departments must use minimum data groupings. Use the minimum data groupings listed on the screen on the right as a part of their IPLAN process. MAP encourages the use of additional indicators to understand the social and structural determinants of health, including those upstream indicators to help define systems of power, privilege, and oppression. Next slide. Thank you. And finally, looking at the community context assessment. So if you go to the next slide, the community context assessment is a qualitative tool used to assess and collect data. It collects insights, expertise, and views of people and communities affected by social systems to improve the functioning and impact of those systems. It helps to understand a community's strengths, assets, and culture. It centers people with lived experience and expertise, and the core activities really include interviews, focus groups, and communicating directly with the community. So there are many ways to collect qualitative data, and those are some of those. And we collect this data through 3 domains, which is the next slide there. These 3 domains, some of them might look familiar for you. The community context assessment essentially replaces the community themes and themes and strengths assessment from the MAP 1.0 and the forces of change assessment, the FOCA, and combines them as a part of these three domains, which community strengths and assets, which is identifying strengths and assets of community members and how to use those to improve community health. Strengths include skills, education, job experience, and community organizing. The second domain is the built environment, which are man made surroundings that influence overall community health, including the individual behaviors that drive health, like green space, housing, sidewalks, street lights, all of the alleys, all of those things. And it includes identifying assets of the physical environment and exploring how community members view and interact with their built environment and how that might impact their health. And then finally, as some of you may know who may have done MAP 1.0, the forces of change are a health equity lens to identify forces that can affect the community and the local public health system. So the forces of change really focuses on trends, factors, and events that contribute to structural inequities. Next slide. Overall, the community context assessment seeks to understand these questions that you're seeing on this screen. They recognize that this assessment recognizes that qualitative data is an essential and rich resource to understand a community better. Qualitative data helps us dig into why conditions exist and how different communities experience these conditions. It helps us find stories from qualitative data collection that provide critical insight into subjective meaning and context and help us understand how and where to intervene. And it helps us build trust with communities is as an important component of gathering qualitative data. And we were mentioning that earlier in our mentee activity. I was seeing a lot about trust and like building trust with your community members. Next slide. So some considerations for the the community context assessment. So before you begin, of course, it's always important to revisit some of these pieces like work plan and budget. Stipends are also something that MAP is considering when doing the community context assessment, especially if you want to get rich data from community members. Supportive and accessibility services like translation and interpretation, what software you're using. Um, all of these things help us inform. And finally, another important consideration to take in account in this assessment is language and political context. There might be a need to change language to meet the needs and political climate of your community, which means piloting testing materials is always a good idea. Um, and there's more information on, of course, on the MAP handbook for additional resources before you begin. Next slide. Thank you. So these steps for the community context assessment are a little bit shorter here. As you can see, the first is really planning for the community context assessment. The second is develop and conduct the assessment and then summarize that data. Next slide. To plan for these items, it's really about deciding how you will tailor the community context assessment to your community and what you aim to learn. So, reflecting back on those domains that we mentioned, reviewing the guiding questions that you developed at the beginning of the second phase of this planning process and the assessment phase, identifying what sources of qualitative data that you want to engage in and revisiting who's engaged and how, choosing those methods. Some of those include group based methods like focus groups, community meetings, or town halls, individual interviews on an individual level, mapping or visualization methods such as community asset mapping, observational methods such as photo voice, and historical research such as viewing historical governmental policies. So, it's important that you decide which pieces of the CCA to choose depending on your time, your resources, and your preference, and ensuring that they fit into the three domains of community strengths and assets, built environment, and current and historical forces of change. The CCA is really great because it can help fill in gaps with the community status assessment. It also intersects with the community partner assessment to highlight how community partners can work together on these solutions. So it's a really great tool for connecting to these other two assessments. Now, you're going to stop hearing from me, and I'm going to pass it over to Dr. Sandra Martell from the Winnebago County Health Department to talk about how they adapted the community context assessment.
So thank you. I also have on with me Patrick Nangum, who's our Director of Data and Quality, who was also critical in this. So this is just one health department's experience in MAPP 2.0. In fact, yesterday we just did our prioritization exercise after combining all the data sources. So next slide, please. So again, I was asked to kind of from Lori and the group to kind of prepare say, how did we sequence our MAPP 2.0 assessments? How did we determine the questions, engaging the community to complete it, the methods for completing and analyzing, and what we received feedback from the community. So we'll kind of address those questions as we go through. Next slide. So we've all seen this before. And again, I think that for us, we had two steering committees. We had an internal steering committee that was comprised of health department employees, and we had partner steering committee, which was really started out with kind of a legacy group and comprised predominantly of healthcare providers who all had some need for assessments, right? Because that's becomes part of this challenge, which is if you were to talk to the areas on aging, if you talk to your hospitals and needing to do needs assessments, if you talk to your mental health service providers and your FQHCs, all have this requirement. So they really became part of that partner steering committee, and they really drove the process. So, again, we know that the community context assessment is really in part of that phase 3 of MAPP 2.0. Next slide, please. So kind of gives you an idea. So we started with the community status assessment. Why? Because I always say that may be considered the low-hanging fruit. Those are your big data sets that you've got. We also reviewed prior IPLANs and the community health needs assessment for Winnebago County and other FAB accredited local health departments to find out what was being included, where were they going. And again, those two committees determined what section outline and the data to be included. And we did partner with the University of Illinois College of Medicine, Rockford. I know got a health evaluation and research group for that portion of it, because we were really kind of looking at updating. So we had census data coming in, we had NHANES, we used the Illinois Youth Survey, the behavioral risk and factor surveillance systems, the community commons data. The next part was, you heard a little bit from Rachel, we did ours a little bit differently. We did a community partner assessment and we did a power primer with them as kind of a concurrent with the CSA. So we were kind of running those timelines concurrently. But similar to the rate, we did a survey to our community partners. After we did the power primer exercise in person, we did a kind of a kickoff to it and asked them then to complete the assessment. And it was kind of a lead on for the next step, which was the community context assessment. And we certainly can provide questions. We were just kind of coming off of yesterday's, but we reviewed our prior assessments, right? We wanted to make sure that we were consistent with all the requirements, both IPLAN and MAPP 2.0. And it was really the steering committees that determined the questions to be asked and which ones should be included, maybe enhanced in terms of some additional data points on there. And then also agreed to do some of the piloting of the questions, right? So that we had some pilot before we released it out to the community. Next slide, please. So, I mean, we've kind of gone through this. I mean, and we probably don't need to go through this again. And again, our components from MAPP 1.0, really, we focused on the community themes and strengths. I mean, you heard about the built environment and forces of change, and we had included that. But this is that really opportunity to kind of get another data point, not only for your quantitative data, because sometimes your quantitative data isn't available and you need to go a little bit deeper dive on some of those areas. Next slide, please. So we chose, we were fortunate enough, and I'll get a final survey, was 36 questions, 35 close-ended, 1 open-ended. And we did content in areas with embedded equity determination. So again, it's demographic information, strengths and concerns of living in Winnebago County, health and health factors, including medical and dental, experience with healthcare systems, and experience with access to resources and quality of life. Now, remember this, the steering committee was driving it so they could use it for theirs as well. And we had one final question, was if you had any additional comments or feedback using an open-ended. We chose, when we had been doing COVID vaccinations, we developed a database through Qualtrics that allowed us to do some messaging to individuals that were interested. So we administered the survey predominantly through survey software. You're seeing just kind of a screenshot of the mobile, but it could be mobile, tablet, device. And part of the challenge, why did we choose that, was that it was available in multiple languages. Because like I think Rachel shared, one of the challenges that almost every organization described as community partners was being able to meet the cultural and linguistic requirements pieces, that we have multiple languages being spoken. We are also a county with refugee resettlement. So we really knew that we were going to have to be able to provide that. And we had learned through our vaccine experience that this platform and the language behind it, they can look at it, their browser in their own languages, they can complete it, and then you can translate it back out electronically for analysis. Next slide, please. So what were our methods? Well, we knew we had to also develop a public messaging campaign, and ours was share, submit, and shape. We talked a little about using our Qualtrics for the community survey. It was multiple languages supported, and it supported multiple platforms. Now, there are some downsides. Remember, we also knew we might have to do some additional paper and things like that, but we did a couple of things. We did active outreach to clients who had previously consented to receive public health information, but we also used our community partners. So from our CPA, we asked for their support if they could then distribute it to their clients, so that we then had a trusted partner spreading that word out. And well, of course, as a health department, and if you come in to receive one of our services, we're always going to ask you for that opportunity. And interestingly enough, we also sent it out with our food inspectors. So after done with an inspection, they could give it to individuals that they encountered. I mean, so I think sometimes we often think of clinical type people sitting in waiting areas, but we also did outreach through some non-traditional kinds of health department work. And we also did, I'm going to call it passive distribution, which is through social media, website. And then we did a media, just an interview about what was going on. Probably the most important thing then when we went out was then we recognized that this was not going to gather information from individuals who maybe did not have access to electronic devices, perhaps were underrepresented. And so how were we going to do that? So we first kind of looked to see where were we getting responses for, recognizing that our next layer would be focus group. Next slide, please. So based on the community survey, we're a population of just under 300,000. We received 2,890 responses through this campaign. So I often kind of, when you think about, many of us in public health kind of step away from some of these large kind of surveys because we are concerned that people won't complete them. There was no incentive given out to complete this, but it was amazing the number of people who decided to submit and share their concerns with us. Next slide, please. We then, from that, looked at who was responding. We got the demographics of individuals who responded, recognizing our largest group that responded was 50 and over, which was another kind of interesting piece. We then went out and did 10 focus groups co-sponsored with our community partners. So for instance, RAMP is our disability community group. We did with the Liam Foundation. We did one in Swahili for our refugee community. We also did with our Winnebago Boone Farm Bureau, the Muslim Association of Rockford. And again, this was the idea of knowing that we were going to have to do further, and we did the NAACP, but the idea being that we knew that there were groups that may not complete the survey. So then the next level. And so we used really trusted community partners to help us kind of co-convene. Now, in these particular groups, the big enticement was the co-sponsoring group could, I'm going to say, ask for whatever food or beverage they wanted. So we had everything from big farm breakfasts to all kinds of interesting tacos and tortas, and others just cookies and beverages. So, that was really them determining what they wanted to be able to entice. And then there were gift cards given for those who completed the participant surveys, but that was not advertised as part of the initial kind of outreach. It was given after individuals participated in the survey. So the idea being we did not want to kind of, I think all of us are concerned about bias in who would participate if we offered that initially. So we had 10 different focus groups to enhance the data. So here are the common things. This is just a word cloud. And I'm sure that if I were to look at almost everyone's who's on the call, if you were to look at most of our communities, mental health obviously comes up as one of the top, the size, violence, economic stability. Some news for us was support needs for aging population, but that was confirmed. Our big community status assessment said our population was aging. You start to see some of these smaller ones, things like food security. Now you see equity was a very small one, but I can disclaimer on this one, we're not talking about the prioritization. Equity became one of the most highly weighted criterion from the community in evaluating the health priorities. So again, these were just common themes that came through: access to care. And we had a little opportunity. You can go to the next slide because it's, we had, I think the most interesting thing was of those respondents, we had an additional 500 responses from the survey question: if you have additional comments or feedback, please provide. I think we were blown away by the number of individuals who gave us additional comment of all sorts. And it was our first foray into using some artificial intelligence to analyze it, because we had not anticipated having to analyze this amount. And you can see the size of the circle again is the frequency of the response. And what we found was quality healthcare was becoming, and when they said access, they weren't talking about, if you had told me 5-6 years ago when people were talking about insurance and the Affordable Care Act, this was, I can't get in to see a provider. I have insurance, but I can't see a provider. And again, this was just various and basic, where there was negative, positive, neutral, but it allowed us to do some deeper dives on some additional, which we expect to be doing with some of our partners. For instance, one of our mental health providers is going to have to do some additional survey questions, but we are able then to identify individuals who indicated that they were having concerns about healthcare and specifically mental health care, and to begin do another cut rather than resurvey them with the same questions, do a deeper, further dive into like mental health issues or social issues. One of the things that came up for us in the social issues category were themes like racism, bias, which was, again, when you think about communities and maybe not wanting to openly talk about it, this is where it came out within the responses to these open-ended questions. Next slide, please. So that was our kind of experience. We just went through the prioritization exercise yesterday. We're going through that. We developed the criterion, the weighting, but I think it really was, we had not expected. And I think as most local health departments had shied away from using as much technology, but what we found was our community was very accepting of technology, and perhaps we're more willing to give and share responses in this kind of a format. We were blown away. As I said, almost 1% of our population responded to the survey. And we then did some, again, for the focus groups with our partners, we did some further recruitment through that. So that was just our experience. Patrick, did you want to add anything to the?
Right, thanks for sharing, Dr. Martel. And just to kind of mention about yesterday's event, it was really interesting to see that we had partners from the different parts of the local public health system. Really interesting to see that we could bring them together, and they really assisted us on prioritizing the health issues that had came up from the 3 different assessments that we've talked about today. And the next focus of the health department would be working together with the partners just so we could develop goals and strategies from their issues that are coming from the different assessments.
Thank you both so much. That was a great presentation and really appreciated the ways that you did this and sharing all of that. Um, and congratulations on the success of the level of input you got. I'm sure there's many people who would like to hear more about your AI experience, so we'll save those questions for later. And if anyone has any questions, please feel free to put them in the chat for Dr. Martell or Patrick, and we appreciate you sharing. And I'm going to turn it back to Samantha to wrap us up in this phase.
Thank you, Lori. Um, Wonderful. So the final piece of phase 2, telling the community story, is to triangulate data, identify themes, and develop issue statements. Next slide. So just to note, but part of this, the equivalent process for MAPP to IPLAN for this piece of triangulating data, themes, and developing issue statements is really prioritizing the community health problems and conducting a detailed analysis of community health problems and inventory of community health resources. So this where this graphic that you see on the slide depicts the entire triangulation process. The process begins as soon as the data from each assessment's been collected and ends with the development of issue statements. So from your left to your right there. Similar to the rest of the steps of phase 2, it's important to work with your design team to identify these issues, these themes, and these issue statements. So first you'll take that raw data and you'll really identify how and answer the guiding questions from each assessment to summarize the data, which can be found in the handbook. And then you're going to think about where that data fits along the health equity action spectrum and depict the linkages between root causes and health outcomes, showcasing the social determinants of health as well. Once the data from each of the assessments has been summarized, which is that next piece, CPA summary data and down the line there, it's time to identify cross-cutting themes. Since you've already been thinking about how the data from each of the individual assessment fits along the health equity action spectrum, highlighting the cross-cutting themes related to the following should be a natural process, which includes community strengths and organizational capacity themes, systems of power, privilege, and oppression, social determinants of health, health behaviors, and health outcomes, and additional data that can inform. And you should be referring to the guiding questions as you developed at the beginning of phase 2 to identify these cross-cutting themes. And then finally, you'll create issue statements from your cross-cutting themes that will identify and summarize why and how the issue occurs, how serious it is, and how its outcomes and impacts. Next slide. So the biggest piece of this, after you've taken all of that data, you've gone through your guiding questions, you've summarized it, you've pulled it together, you've developed themes, is to develop your issue statements. So the issue statement is a 1 or 2 sentence statement that identifies and summarizes why and how the issue occurs and how serious it is and its incomes and outcomes and impacts. Issue statements should answer the following questions: who's affected, how big is the issue, what contributes to the issue, and when and where the issue is most likely to occur. You can use the data from your assessments that you highlighted when identifying themes to answer these questions. Also note that in the process for IPLAN, the assessment includes a description of the health problems most meaningful for the community by grouping. So you can see here again as a reminder, these are the groupings that are required as part of the IPLAN process and that can be used when you're going through and developing your issue statements. Next slide. Another piece of triangulating this data, once you've developed these issue statements, is to conduct a root cause analysis. So, the purpose of the root cause analysis is to understand the cause and effect relationship for health issues and help reveal the systems of power, privilege, and oppression that impacts health outcomes. Conducting a root cause analysis of each issue will help you build out the components of your issue profile, and it really helps you highlight, or I'm sorry, and MAP highlights two methods for root cause analysis that are most helpful when looking at issues relating to communities' health and well-being, which are the fishbone diagram, and we'll really quickly look at the 5 whys in a second. Note that for IPLAN, a description must be included in the priority selected, which are a required minimum of 3. The description includes the importance of the priority, summarized data and info, of which the priority is based, the relationship to healthy people, national health objectives, and the factors influencing the health of the or the level of the health problem. So you you'll see in the iPlan workbook risk factors, direct and indirect contributing factors, and populations at risk. So that's important to note when doing this. An example or method of a root cause analysis is the 5 whys here, and I'm not going to get too deep into it, but it's really an activity to systematically identify the root causes of a specific problem and the relationships between these root causes. So it's really a way to help identify and consider the cause and effect relationships, and it can be used with the data from the 3 assessments to complete this tool. Next slide. So that is essentially, you've gone through, you've identified themes, you started building out priorities, all these great things. That's how you get into phase 3, which is continually improving the community. So, the goals of phase 3 are to identify strategic priorities for the CHIP across the health equity action spectrum that meet your community's needs, strategically align with your partner organizations by developing issue subcommittees, develop shared measures to track activities, develop an action plan to achieve the community vision and goals, and do continuous quality improvement on strategies as they are carried out throughout the process. As you can see here, these yellow stars again, within phase 3, the steps of phase 3, you'll see here, first are prioritizing issues for the community health improvement plan, doing a power analysis, which we'll talk a little bit about that later. Identifying subcommittees, creating partner profiles. The big pieces here, of course, as we all know, are developing shared goals and long-term measures, selecting your strategies, developing continuous quality improvement planning, and action planning cycles, and evaluation and monitoring. So you'll see the stars here. The equivalent for that first piece is really the prioritization process of iPlan. For developing your shared goals and measures are part of developing the community health plan. The community partner profiles are part of identifying the factors that influence the problem. And of course, finally, doing the continuous quality improvement is the equivalent of that in your iPlan process. Okay. Oh, sorry, I lost my screen there for a second. So the first step is really prioritizing the issues for CHIP. So at the end of phase 2, the community developed a set of strategic issues based on your community health assessment findings. The next step is to finalize the prioritization of these issues. Prioritization allows the community to narrow down the issues to a manageable number so it can target resources, use existing efforts, and develop achievable goals and strategies to address community needs. So as you can see here, the prioritization process includes reviewing the issue profiles and determining whom to involve, determining the criteria for prioritization, what you're going to use, validating the priorities, and sharing the results. The prioritization process can be done in many ways. There's no right or wrong method, but there are pros and cons to each. The method you select will depend on how many issues you have to narrow down, how many people will participate, and how many people will participate. There is a prioritization guide in the MAP handbook that goes through some descriptions of each method. And there are multiple options like multi-voting, which is used to narrow down a long list of health problems, or prioritization matrix, which is common when using health problems are considered against many criteria. There's multiple options that you can review in the MAP handbook. It's important that prioritize issues resonate with both community members and those in the local public health system. Centering equity in this process is really important and can be done by involving community members, especially those who are impacted by your health inequities. Sorry. Next slide.
Yeah, I think I'm going to pick up here.
Yep.
So the next step is that power analysis that we've been talking about. And for the power analysis, again, this can happen in phase one, when you're looking at stakeholders that you're bringing in, but you're also doing it again or doing it in a different way here in the phase of the chip to see who has power related to the priorities that we have selected. So you remember for IPLAN, you have to have a minimum of 3 priorities, and you could have more, but you have to have a minimum of 3. So thinking about those 3 priorities for each of those, you're going to have goals, and you're going to have be developing a set of strategies and action plan. So you want to identify who needs to be involved in this, who could influence this, who could have power over this, who do we need to bring in, who does this affect the most. So the goals of the power analysis are to assess who those folks are that could have an impact on the priority issue, identify who the issue affects the most, and where's the opportunity to build their influence, and identify factors and people who are perpetuating the problems related to this particular issue. So we're going to identify who the folks are, determine who's aligned or who has power to influence it, and consider how to engage them. Those are the steps in this power analysis here. So the first thing is we take a look at the 3 faces of power. So there are some folks who have that visible power. These are clear decision-making bodies that exercise their influence to achieve a particular outcome. So they have influence, direct influence on the final decision. They are oftentimes our legislatures, our local policymakers, county boards, those types of things, heads of organization, people who are in those public-facing, visible power positions. And there's also hidden power. So those who create the decision-making environment and set the agenda. So they can oftentimes determine who will make the decisions and what they will consider. And then so we might think of lobbyists, we might think of people with money, funders. There's a variety of different folks, advocacy groups, there's a whole bunch of folks. And then we have invisible power. So those who shape the way we think about things, the information, the beliefs, the worldviews, social view issues. So if you think about an issue like COVID and vaccinations, there were people in visible power who were saying what the mandates and requirements were. There were people in hidden power who were creating that environment and setting the agenda of what that would be and informing that decision. And there was invisible power, that sort of undercurrent. We saw that a lot in the media and social media of influencing decisions and providing information to people that shaped their beliefs and their views about that. So how will the public think about the issue, and who has the power to affect what the public thinks about it? So think about those phases of power as we're going through this next quick activity. Power contributes to the health inequities, and it can also be used to leverage how we address those health inequities. So that's why we think about power in this phase. And a power analysis, when we're looking at it for the CHIP priorities, can help us identify who needs to be involved in addressing the issue or the priority, who has an influence on the issue, and what their support of addressing the issue is. That's what we're really trying to determine here. So we look at who has that power, positive or negative, who are the partners, who's supportive, who's working in favor, and who are the opponents, not supportive and working against. So those process steps are we're going to brainstorm and identify a list of potential people. We're going to analyze them and then we're going to decide. So for this quick little exercise that we're going to do as a large group instead of in breakouts, if the community health profile was related to chronic disease and the goal was around children under 10 years old eat 3 healthy meals a day. That's the goal that you have decided and what we're going to be using. So children under 10 years eat 3 healthy meals a day. The first thing is I'm asking you to just brainstorm some organizations, groups, and individuals that would be related to that issue. Who has some kind of stake in that issue? Who might be related to that issue? Just put your ideas in the chat. What are some organizations, groups, or individuals that have some kind of relationship to the issue of ensuring that children under 10 have 3 healthy meals a day? So put those ideas in the chat. I'm not seeing chat activity. Are you, Samantha?
I am.
Oh, you are. Okay.
Got schools, DCFS. Do you want me to share my screen?
Yeah.
If you don't mind stopping sharing.
Oh, I have to
Oh,
stop.
actually, maybe you might not have to do that.
Here we go.
Here, you can go ahead and reshare your screen and I'll share mine as well.
I stopped sharing.
You can share again. I made it so we can share it at the same time.
That's okay. I'm good.
So we've got so far schools, DCFS. Y'all are doing it faster than I'm typing. Child
Parents.
care, parents,
These are great ideas.
aftercare programs, food industry,
Park District.
pantries.
Park District, pediatricians, doctors. So what you would do is you would brainstorm these and you would plug them into this potential partners and opponents table. So let's take a couple of these and just work across here. Blessings in a backpack group. Great. That sounds like a great group. Kids, young people, right? The kids under 10. So we're going to take a look at this table and just try to fill out a couple of these categories. So what could let's look at parents. What could their impact be on this issue of kids eating? And Samantha, I can't see this very well. Can you tell me what it says under impact or tell the group?
Yes, and I can zoom in as well. So impact, how are they influenced by the issue? Impact could they have? And also this handout that you're seeing here has been dropped in the chat, so you can open it up yourself on your end too.
Thank you. So impact, how are they influenced by the issue? How are parents influenced by the issue? And you can take yourself off mute or write in the chat.
Or if you raise your hand, I can take you off mute. Or drop in the chat that you would like to speak and I can unmute you.
So parents would need to be, right? They're responsible for feeding the kids. They would have to ensure that they have the food to feed their kids. And there's other things that we could come up with, but we'll just do a couple answers for each. Under relevant power, what type of power do you think they have related to the issue? What do you think their relevant power is? And I'm keenly aware of the time.
Foods they buy.
Yeah. What they can afford, what they can access, right? To whom are they accountable? Who are the kids accountable to? so they also live with kids who are, and they're instilling habits on the kids. Parents have a lot of power to choose in the home, but they often don't have a lot of control over what the school provides. So they're accountable to their kids. Who are they influenced by ultimately? Who are parents influenced by in terms of what they feed their kids? They're influenced by the environment of what's available to them, right? They're influenced by their kids and what their kids will eat. Who else? By family and culture. Great. By their budget, for sure. Advertisements, yes. And are they supportive or against making progress on this issue? Would you say overall parents are supportive or against making sure their kids have 3 healthy meals a day? Most of all, overall, probably supportive. Yeah. So if we would move on to the next phase or the next question of this process, we're not going to have a lot of time, but let's just think about where parents would fit on this power grid. Okay, so you can see that along the X and Y axes, we have different levels. What's their level of support? Are they diehard against? Are they diehard support, active support, inclined towards it? So where would you put them along this spectrum of support? Which one of these? Where would you put them? We think they're supportive of this, right? For sure supportive. So which level? Would they be inclined or active support? We're going to go with inclined. We had a couple people say inclined. So now let's think about power. It's not on their radar. We can get their attention. They're probably taking this into account. They have a power to have major influence on decision making. They have active decision making. They have decisive decision making. They don't have all the resources in the world, right? We're talking about your average parents. So they would be inclined if they have the resources, right? So now let's look at the power level. Where are they? Taken into account sounds about right. So we have them in this category right over here. So inclined and taken into account. There might be some other parent groups who maybe are well resourced and live in a well resourced community and might be not having a problem ensuring that their kids have 3 healthy meals a day. And they might be up here at power to have major influence on decision making. So you want to look at where they plot out on this power grid and have discussions about then how you will engage them based on where they're at and what you know. So we don't have time to process this out anymore, but this gives you an idea how to look at this tool, see this tool, and think about how you might use it. So thank you, Samantha. And we can go on. Okay. So after you have developed your issues, you prioritize your issues, you're developing your shared goals and your long-term measures. You have the folks who are doing this with you are the stakeholders that you've engaged. You're thinking about how they're involved. And MAPP 2.0 provides a nice template for thinking through this plan and coming up with those objectives, those strategies. It's different than what you have in IPLAN tools, but these things can be supplemented together to provide a nice planning framework. The last piece that I want to cover before we're closing out here, as we're in our last minute, is just letting you know that there are MAPP resources and training available through NACCHO. You want to ask these questions. Is MAPP right for you? Samantha has a handout with more information on is MAPP right for you? And if you do want to use MAPP, you do need to submit a letter to Joanne Bardwell, the IDPH administrator, stating that you want to use the equivalent planning process before you start that. This is the crosswalk that we mentioned earlier. Here is additional links to the actual MAPP documents and tools. I encourage you to peruse that a little bit, even if you're not ready to use MAPP and you want to just look at some tools to supplement your existing process. And as we close out today, Samantha's putting an evaluation in the chat. We really do need your feedback. We have committed to IDPH to have at least half of you answer the survey. So we didn't meet those numbers last time. If you'll please help us out and answer the survey and give us your feedback, that would be really helpful. Our next webinar, we have two coming up in October. October 10th is a technical assistance session all on iQuery. We'll be hearing from Dr. Frida Folcom and her team about new updates and the data that you can access in iQuery and a demo. And then on October 24th, we'll really be digging more into that power and piece and integrating racial equity into your IPLAN process, regardless of whether you're using MAPP or IPLAN. So we look forward to seeing you on those dates. We have extended all the trainings by a half an hour to 12:30 to 2:30. And despite that extra time, we still ran short today. We will be more timely in our next session. Thank you so much for joining us. And thank you again to Rachel and Dr. Martell. Those were excellent presentations. We are so happy to have Illinois frontrunners in leading and using this new model. So thank you so much. We will be sending out the slides and materials and the recording and any responses to questions that we did not get to. Those will go out within a week. And thank you so much.
I will leave this up on the screen as well as continue to drop the resources in the chat for those of you who maybe didn't get them.
Oh, I bet people couldn't access the evaluation. Samantha, can you send that out right away, the eval link? I don't think they can click on it in the live presentation unless it's in the chat. They can't click on the slide and get to it.
There's still folks on.
What'd you say? Samantha?
1 second.
Oh.